And then Christine and Aaron, as you're seeing people come in, can you let me know when we should just go ahead and get started? I certainly want to give some people a couple minutes to log in, but want to make the most of our time as well. Or if I can just go ahead and get started, that's fine too.
Usually waited at least like a few minutes after, so maybe give it just a few more minutes and then you can get started. The intro stuff has mostly links that will also be at the end as well. So
Yes. Okay, sounds good. We'll give everybody a couple more minutes to filter in. Aaron, are we good to get started, you think?
yeah, I would go ahead and then people will filter in and out throughout the hour.
Okay, sounds good. We just want to make sure we make the most of our time for this afternoon. So we'll go ahead and get started. So good afternoon, everybody. Thank you all so much for joining us today. So we are at the Together in Care Advocacy Campaign webinar sponsored by the AAP section on neonatal perinatal medicine, trainees, and early career neonatologists. My name is Tammy Young. I'm a neonatologist in Maryland at Johns Hopkins Howard County Medical Center, and it is my pleasure to provide an introduction for today's webinar. And so for today's webinar, we're departing from the format that we've had for most of the webinars throughout this campaign. I've learned so much from our experts in terms of their wisdom in developing palliative care skills. But we really wanted to provide a little space and time for recognizing that developing those skills is really an ongoing process, an ongoing journey that even when we have really solid skills, we can still make mistakes. We can still deliver news in a way that doesn't land the way that we had hoped or intended for it to land. And so we really wanted to provide a space to make use and learn from those experiences. And we really felt that the best people to help us in that learning endeavor would be parents of the families and patients that we take care of, who are with us on family-centered rounds, are with us sitting across from us at the table of family meetings, and hope that by sharing their experiences, we can learn for future and improvement of our own care. And so, with that, we will be having a panelist discussion moderated by Dr. Terri Major-Kincade. And we are joined by David, Jana, and Taylor. Thank you all so much for joining us. So, Dr. Major-Kincade will moderate a discussion for the majority of our webinar today, but we also wanted to invite your participation as audience members. So if you have any questions for our moderator or our panelists, please place them in the chat and we'll be moderating and checking the chat out for questions towards the end of our hour here. And so with that, we'll go over just some learning objectives for this afternoon. But before that, let me also invite you all to our next webinar in January, where Dr. Weaver will be talking about pediatric hospice concurrent care. And so please register for that, and we look forward to seeing you in January. For today's webinar, our learning objectives are to share family experiences and perspectives of what didn't work well in communication, and recognize moments of harm for families as we carry on care in the NICU, and then find
The screen is frozen.
in Texas. Hi. Are we
Oh,
still
hi.
on?
Yeah, we're still on, Tammy. It
Okay.
looks like we had an internet disconnection.
Apologies. I will carry on with my introduction of Dr. Major-Kincade and pull up my slides towards the end. So she um, has research interests in perinatal health disparities and inequities, provider and parent communication, implicit and explicit bias in healthcare and provider well-being, as well as increasing diversity in the healthcare workforce. So thank you all again so much for being here, and I will hand it off to Dr. Major-Kincade.
Thanks so much, Dr. Young. Hey, everybody. I am excited and honored to be here. And Tammy, I'll say I've been known to break the internet before, so I guess we did it again. In- anyway, I am just so honored today to introduce to you these two families who I had the pleasure of caring for and meeting their children and walking alongside their journey. And I would just echo Dr. Young in just saying that parents truly are our best teachers. And they are always teaching us how to be better. They're the experts in the care of their children. And I'll just start in advance thanking Taylor, David, and Jana for being here and sharing the legacy of their children. As we noted on the original slide, we have a couple of objectives today, and we're going to use their stories to allow us to meet those objectives. And I'd just like to start by asking Taylor first, and then David and Jana just to share a little bit about themselves, about their child and their journey in the NICU. You're muted, Taylor. Okay, there you go.
All right, so I am Taylor. This journey started for me when I was pregnant with my son Adonis. Initially, everything was checking out to be fine prenatally. He was due in May, I believe, and it was around the end of December I noticed that I hadn't felt him move in a couple of days. I worked overnight and I also have like a 7-year-old son. So I didn't sleep as much as I should have. So I was like, I'm pretty sure he's not moving. I'm not just missing this. And so I went through a series of visits with emergency rooms and hospitals trying to get confirmation. And everybody, for the most part, they were pretty dismissive. He had a strong heartbeat. Oh, he's fine. And it wasn't until I got to about that fifth place when I noticed that he's been in the exact same position every time that we did an ultrasound. And the doctor looked back and agreed and then sent me to a specialist. And that was when we came up with the diagnosis of arthrogryposis, where he has contractures and his joints are locked. Um, and then from there, we continued to watch him closely. And we realized that he was not doing the practice breathing, swallowing the amniotic fluid. And upon further review, they found that his lungs were very small. They told me that they would not be enough to sustain life, even if we got him onto a ventilator. in enough time. And that was when I got the engagement of the CAPS team and the support there. But when he was born, he did take to the ventilator, and he's still here now. But that is how we got started here.
Thank you, Taylor, for sharing your journey with Adonis and those initial concerns you had as his mother, knowing that something wasn't quite right and looking for answers to that. And I'll just say I always remember meeting Taylor in the fetal center because she told me that his name was Adonis and it means something greater than ourselves. Um, and that always gave me chills. We're going to talk a little bit more about her journey, but thank you for giving us the introduction to Adonis Taylor. David and Jana, I would love for you to share a little bit about your beautiful daughter and your journey in the NICU.
So our journey started when I was about 14 weeks pregnant with Haley. We found out she most likely had trisomy 18. And so we had lots of anatomy scans and care to make sure she was doing well. When I was about 32 weeks pregnant, our hospital we were at told us if we wanted to do anything other than hold her and let her pass, that we had to transfer to another hospital. So that's when we met the fetal center and Dr. Terri and got started there. Haley was born at 37 weeks. She spent 99 days in the NICU. And then we went home for about 10 days. We had to bring her back in. We went to the Heart Center ICU and we were in there for 5 weeks. Took her back home, got to spend Christmas at home with her. Right after that, we took her into a second hospital to get a second opinion. And that's where she passed away. So got to spend 6 months with her.
Thank you, David and Jana. I too remember that like it was yesterday and how much research you guys had done when we got to meet you initially in the fetal center. And I didn't say hey to Phoebe. Hey, Phoebe. Thanks for joining us as we talk about your big sister, Haley. Um, as I think about both of your journeys and just the information you received in those early months before your children were actually here, I'd like to just kind of move on to that initial point in the NICU, and I wonder if there were experiences or communications from the care team that made you feel unsafe or made you feel harm as a parent as you attempted to navigate that process in advocating for your child. I'll start first with Taylor as you reflect on Adonis actually being born and being admitted to the NICU, if there were care experiences or communications that you specifically remember that felt unsafe or you perceived harm.
Okay. After birth, Adonis stayed in the NICU for 6.5 arduous months. They were trying times. Um, there's a bit of it where it was difficult just because of the amount of uncertainty. I like to consider myself a person of science. Science is one of my favorite subjects, and I understand it. Even there, we have our limits. Um, and unfortunately, my son, he likes to play outside of those limits. Um, some of the things that were particularly hard, though, there were inconsistencies with communication. Um, I feel that I did what I could to be as informed about everything that I knew that he had going on as I could be. We would have meetings and conversations, and then later I would still see things on paperwork that I hadn't seen before. When we discharged, we had the severe diffuse encephalopathy, and nobody had talked to me about that. Nobody mentioned what does that mean for him. There were a lot of times where when we would sit down and talk, it would feel kind of rushed. Um, and that's something where I have understanding for it because I understand that it's a whole hospital and it's not just my child, but the feeling rushed or feeling like not necessarily there was something better for some members of the team to do, but you could kind of tell that, like, okay, we're ready to be done, and I have more questions. I'm trying to get understanding. Um, Goodness gracious. There were it was just really big for me having the meetings. We would have the conversations, and then when we discharged, there are several diagnoses that I have no information about. Um, I remember there were some things that we found out about his brain kind of early on, and I asked, well, do we expect that we'll have full intelligence and competence? And I was told yes, and then later on from someone else, I was told no. Um, Goodness.
Gosh, Taylor, I hear a recurring theme. Thank you so much for sharing that. I want to highlight two things that you've kind of woven through the story. The first was the uncertainty, acknowledging that we don't know everything that's going on with Adonis, but some of the things we did know were going on were not conveyed to you in meetings or in a way that you could process them the way they were printed on paper. And just the additional uncertainty or harm of not having transparency or information and all the things to expect for him. I can't imagine what that's like to kind of read diagnoses on paper. And you just said you love science. I actually hate science. I'm in medicine, but you love science. And so wanting that information and wanting to be present for the meetings and then not getting all the information that you possibly could about him. So I also want to hit on this, the rush. So creating space intentionally for families. We try to create space, we try to have meetings, but having the perception that even though space is created, it doesn't feel like that's the main priority in that moment. Um, and I think that's a very astute assessment in the NICU and working to figure out how we can be intentionally present for families in the moments when we are able to create those spaces. Thank you for sharing that. The harm that words spoken and not spoken, I'm just struck by the written words, the harm of those, and the harm of uncertainty.
If you don't mind me saying it, it also just peeling back mentally, thinking about how I know that we have certain diagnoses and we have expectations for them. Um,
Mm-hmm.
like what we've come to know that these diagnoses tend to mean. Um, I do feel like it was unnerving when we're already just trying to keep fighting through the time that we have right now, and then having some of the staff members that we would work with make comments. I remember once before asking about transporting him. How does it work? All his equipment in a car seat. And one nurse, she kind of just abruptly was, he's not going anywhere. It doesn't matter. And that was kind of devastating. Where I understand like realism, we need to be safe when we move him, but just the total exclusion. I feel like he was counted out a lot in the beginning, and he's still fighting quite a bit. He's still putting on a big fight.
I'm so glad you shared that, Taylor. I remember that feeling erased and wanting to advocate for the future that Adonis was going to have, whatever that future was going to be, and wanting resources. And what I hear you saying is we can name the expectations, but we can also hold space for a potential future. And our job is to kind of empower you for whatever that future is going to be so you can meet that need. Thank you for sharing that. David and Jana and Phoebe, I am going to ask you guys, as you guys kind of think about that initial admission for Haley once she's born and admitted to the NICU, if you can remember any communication experiences or words that caused you harm or scenarios in which you didn't feel safe.
So one thing was as soon as she was born, Haley was intubated. And we knew that she was difficult to intubate. It took a little while for them to get her intubated. So she was about 4 or 5 days old, and a doctor came up to us and said, we want to extubate your baby. And then just walked off, and then turned around, came back and said, "Oh, and I want y'all to think about putting a DNR on her," and turned around, left, and didn't talk to us for 2 weeks. Us knowing that she was hard to be intubated, thought that, oh, you're trying to just take our baby off of her support and let her pass away. We didn't know anything about that. It was all new to us. And 2 weeks later, the doctor came back, sat down with us, and explained everything, the whole process, showed us the tools that they would use, what would happen if she needed to be reintubated, all the things. And then we had a totally different reaction than we initially had, because we were given the information that we needed rather than just dropped on us and left. And the doctor could visibly see that we were upset, by the first conversation, but we needed the explanation, and then we wouldn't have been as upset. And then I think another thing was just repeatedly telling us that these babies don't make it to a year. We knew the statistics that it's about 90% chance, but there's still that small chance that she could. And we were holding on faith, that she could be in that small percentage. If the doctors saw something specific that told them, oh, she's not going to be in that larger percentage, then we would be totally understanding. And but just to repeatedly tell us that and give us no reason, and say, not say that she most likely won't, but just she's not going to, these babies don't, when we know families that their babies are 4 years, even 10 years old. And we did know the difference between full mosaic and all that. So that was another thing.
Thank you, Jana. I think it's such an important point that you and David are raising in along the same lines of sailors, that families can hear information, understand very clearly what you're saying, and still hold space for a potential future for their child. And they deserve to hold space for that. And I love that you said that the reason the information hurts, or the reason information is hard to hear, is because sometimes healthcare teams don't share the information with an explanation. And just allowing additional information for an explanation for why you're making the recommendation you're making, or why you're saying what you're saying. That's different than all the other statistics that you've heard, and the families that you've seen, could go a long way. So a big part of psychological safety is in those initial words, in those early days, as you guys are trying to navigate that course. Those words, you said people kept saying it every day that she's there, and you guys are fighting, you're hearing these same words without explanation. So I want to say to both of you guys, I am sorry that part of your journey involved an erasure, of your attempts to advocate, for all the realms of possibility for your child, all the realms. So holding space for both. And I want to applaud you both. I think a lot of people don't understand what it's like to be able to hold both. And you guys clearly from the beginning were able to kind of hold both realities for your children. And I want to applaud you for that. It's a pretty big deal. So we've talked a little bit about things that you guys can clearly remember in your journey where you may not have felt safe, um, communication styles that maybe you didn't feel safe in your advocacy, or you perceive some harm psychologically after you're trying to navigate. But I wonder if there are counter experiences where you clearly felt seen as a parent, heard as a parent, valued in your advocacy, that allowed you to navigate that journey that much better. I'll start, since I keep picking on Taylor first. I'm going to pick it on Jana and David this time.
So from the very beginning, I would say the fetal center and the CAPS team, the palliative care, did absolutely amazing. they were there for every question, not just as doctors, but as friends as well, to make sure that we were totally taken care of, understood, had everything we need. So they did an amazing job. I feel like we did get off um, kind of on the wrong foot with some of the doctors at the NICU, but I feel like it turned when they so Haley, she got a trach. And so when they saw, we were there every day, we totally understood everything that was going on with her. Um, we got all of our training when they, saw that we kind of knew her very well. Um, we were prepared to take care of her. That's when it seemed like that they were really listening to us. If we brought anything to them, brought anything up, it felt like, we were really seen and heard at that point.
Sounds like once some of the really, really hard decisions have been made and you're actively living, breathing, walking life with your child on technology, you guys were kind of able to have a sigh of relief, and sounds like the medical teams were as well. Do you guys feel like you were well prepared to take her home with the trach, or do you feel like there was communication there that was lacking?
We were well
I know the
prepared.
answer,
The
but I would
training team was really great. Yeah, they were all awesome.
Before I ask Taylor, I have another question. Sometimes healthcare teams worry about introducing palliative care in the fetal center. They think that may cause families distress, or families may perceive that as taking away their hope. What was your reaction to meeting the palliative care team in the fetal center?
It was just like an extra layer of support, someone that would stay with us kind of and follow us. Y'all were there, the fetal center, the NICU. We came back to the heart ICU. Y'all came up there and saw us frequently. So it was nice to have someone to kind of follow along and have that consistency. It wasn't for us scary or anything. It was really nice to have.
Thank you. If it wasn't, you could tell me. Okay, Taylor. I wonder if there were moments in your journey with Adonis where you felt seen, valued, and heard as a parent, and how that helped you in your advocacy for him.
So, not to just copy off of Jana, but when we would have family meetings and you all were there with the CAPS team, I feel like y'all were about the most supportive branch of the group meetings that we would have. And to have that support, that did feel really good, especially when there was just so much uncertainty and it was a lot of hardship that was going on. But to have the support to feel like what I was saying was valuable, that was nice, because I felt like it would go kind of 50-50 in the meetings where me having my information and my questions, it would just be like, okay, this is going on too much. But then having, have the group kind of like, okay, this is good that you're paying attention, that reassurance, um, that did feel good. Um, just having somebody that had a good understanding of everything that was going on, more than I believe I did, for me to be able to bring my information to them that I was able to find and have those conversations. That was nice. Yes.
So I love that you said bring your information to them. So it sounds like in the family meetings you did a little bit of research.
I'd have my notebook ready, because the like I said, sorry. So some of the information we did not find out about until discharge day when we got those discharge papers, but most of the things in between, if I didn't hear it directly from a doctor, then I would hear it from nurses during shift change. Um, and at that point, that's going in my notebook, and I'm gonna do a little bit of research to get a good understanding, because the way I saw it, I could either be overwhelmed and overrun with this information, and like sadness, if you will, or I could just try to get on top of it and get an understanding. And so that was what I tried to do. Um, I want to say that the nurses there, we had really nice nurses. It felt like having an extended family, knowing that when I wasn't there, so I had to either go back to work or tend to my eldest child. Like these nurses in the NICU, they were really good, and I felt like they really cared about my son, and that felt good too, to know that it's not just the job.
Yeah.
Yeah.
And I know that Adonis had a trach as well. Did you feel supported in terms of being ready to go home when you got ready to take him home with this trach? Did you feel like you were prepared for that, or was there types of communication that could have been improved in terms of your discharge planning?
The only thing that I had an issue with discharge was the day of discharge. I thought they were going to cancel it and say we're going to have to keep Adonis because he was having milk coming up out of his mouth, nose, and trach. And we later found out that it was blood as well. There was brown substance. They would say, "Oh, it's just digested milk that's coming up." Later found out that was blood. So at discharge, I thought that we weren't going to go home because he was still refluxing at that time. But aside from that, the idea of the trach and the G button, it gives me a little bit of the heebie-jeebies. But we had really good, solid training. The respiratory therapist that came, and then being up there with the nurses, allowing me to be hands-on, seeing PT and OT come and like move him around and do the things. It's like, okay, I did have a lot of time in his 6.5 months, so the idea of that technology being there, that still kind of blows my mind, but I did feel comfortable with management and care. Yeah.
Thank you guys both for sharing the parts of your experience that were hard to navigate based on some of the communication, some of the things that you maybe heard during sign out or saw on a discharge summary that you didn't hear during the meeting. And thank you for sharing the ways you were affirmed as a family with having a team follow you for the journey, but also being empowered to advocate for you, Taylor, during the family meetings. And I can't remember David and Jana about the family meetings for Haley. I think I'm not sure if there were as many family meetings, but can you share a little bit about the what you do recall from the family meetings or being prepared?
Yeah, so in the NICU, we only had one family meeting, and that was when we were like officially saying that yes, we were gonna go ahead and do the trach. We had already discussed it with doctors and different people. Um, I think Child Life had brought the little, I can't remember, bear or whatever it was with little trach. So we had had the whole conversation. That meeting was strictly about that. So that's the only one we had in the NICU. And then once we were in the heart ICU, things were pretty crazy there. And so then we started getting the family meetings going, and that's when everything, like we had all the specialties there, got on one page, and it was much better. But yeah, the family meetings would have been helpful in the NICU as well, because like Taylor, it wasn't nothing huge. We knew her large diagnosis, prior to her being born, but it was, the smaller ones that we were finding out by, being there when the nurses were doing shift change and them giving report to the next one of what was going on with Haley. So yeah, family meetings would definitely have been great.
Great, thank you. I want to ask you guys what I call the $1 million question and why I wanted this to be called do-overs, because I think in my career, all the conversations and all the families that I've met and things I wish I could have said differently or things I wish I could have done differently. And which is why I'm so grateful for your bravery and your courage and sharing your journeys. And I'm going to ask both of you. I'll start with Taylor. If there's one thing you have like $1 million that you have the magic wand and you can change it for all the future generations of clinicians in the NICU, what would be one thing that you would say to the care teams to help us care for families better, primarily in our communication style and creating a psychologically safe environment for you that does not contribute to the trauma of already the NICU having to be admitted to the NICU?
So my one thing, it's a compound thing. I'm not prepared to just say one.
Well, it is $1 million, so yeah, you can say more than one thing.
I remember feeling like it was particularly hard for me, going through everything that we went through in the NICU because I couldn't follow a paper trail for diagnosis. They did not have, um, like a my chart kind of thing that I could log into. And I know that's not on the doctors and the nurses. That's a more technical thing. But just having some type of paper trail because you
Hmm.
talk to one doctor, we're on a new rotation and they're saying something different. So communication, um,
Hmm.
clarity with our test results and just how we discharged and we saw things that, we hadn't heard about before. Um, the importance of family meetings. I felt like they were really important. Even though sometimes I did leave feeling like, okay, I'm in the same boat I was when I got here. Initially, I feel like they were really important. I guess the one thing is just the willingness from the team to really be willing to, when we get everybody together, to just really say this time is for this. Because I have the understanding that this is a hospital and my baby is in this pod and there are several other pods full of babies and that they're rotating and caring for them all. And so I do understand that it's busy and understand that emergencies happen. And I don't mean to say that it's not, but sitting in those family meetings and just feeling like Adonis was, I guess for lack of better words, another cog in the machine when it's like he's a whole person, not just a little cog. Um, so just the willingness to really sit down and try to help us understand what we don't understand and try to help us get the information. Just thinking about how just sometimes I felt like me having my questions was a little bit of a burden. Like I could see it in their faces. Nobody would say it outright, like, "Oh, we're ready to go."
Hmm.
Just just really, I don't know what it would take because I'm not in that field at all. But to just really be able to dig in and be willing to give that genuine time, to be thorough and whatnot for the family. Um,
Thank you, Taylor. I think that's huge. I also want to applaud your graciousness. You lead with, I know you guys are busy. I know the NICU is busy. I know there are other babies, but this is your time. He's your one baby. He's your one Adonis. And this is his time and leading intentionally. And I do think a lot of that is nonverbal. Parents can read the cues. They can see the rush. Is everybody sitting down or people standing at the door or people getting up while you're still talking and just really being intentionally present. As you mentioned, once you actually set aside the time for the meeting. And I know a lot of times you were rearranging work and stuff to be there. So I do want to be able to summarize, but making sure we are fully intentionally present in a way the family feels that for this moment, their child is the most important thing to us. And then secondly, you guys both kind of shared this notion of improving communication, being able to follow a paper trail, being able to access the chart in a way that you can kind of keep up with the diagnoses in between the teams. And one thing I heard you both say was it may not even be like a big diagnosis, but it could be big diagnoses or things the team feels like is a small diagnosis, but it's something you did not know about your child. It is another label attached to your child that you weren't aware of, and just really creating time intentionally to go over all of that. Thank you. Um, Thank you for sharing, Adonis is really lucky to have you um, as his mommy. All right, David and Janice, same magic wand. We get to do the do-overs, and you can guys tell us how we can support families like yours better in the NICU and our communication and creating space for you.
So I think one thing with diagnosis is, with any child, but specifically speaking to, children that maybe are considered terminal or that aspect, whatever you want to call it. Not just looking at the diagnosis, but looking at the child specifically, um, So when we were in the fetal center before Haley was born, we were kind of given like three things that she was definitely going to need. And one of them was the jaw distraction. And so it wasn't kind of like, oh, maybe it was more like, okay, she's going to need this. And that was really the whole goal that we were given at the beginning of the NICU is she's got to get to this certain weight. And okay, she's gained this much. We're getting closer. And then when we got there, they contacted the team that would have did the surgery, and it was, oh, she has trisomy 18. We're not doing that. Um, and so I think just not just looking at the diagnosis, but the child themselves, and if there is a specific reason to not do it or sit down and have that discussion. We were really upset when we were told that because we were like, y'all are just denying based on her diagnosis, not her specifically. And we had made a friend with a doctor that her little boy has trisomy 18, and I believe he's 4. Um, and he had the surgery, and she told us that it did not help him. He still had to get the trach. And that's really when we were like, okay, well, that's possibly not the best thing for her because, they go through all the pain and the extra time and all that. And then we were okay with it once, we had the discussion of, maybe it's not the best thing for her, but just telling us, oh, she has trisomy 18, we're not doing that. That wasn't particularly the best way to handle that. And then one other thing is, like I said, she went home with the trach, so it was obviously is not the easiest to take her around to other appointments. And we were told in the fetal center that it looked like she had a club foot. And then we heard, once she was in the NICU, she got an x-ray. We didn't ever hear anything about it. So towards the end of our stay, we asked about it maybe a month before we left or something like that. And we were told, oh no, it looks like she's possibly missing a bone. And so we asked for the specialty to come see us to discuss, that. And we were told, oh, you'll have an outpatient appointment. And so I'm sure that team was there seeing other babies. They could have stopped and, communicated with us, whereas we had to drive an hour to be told that all they could do for her was cut her foot off. And so that would have been helpful for them to just communicate. It was two little sentences of, oh, this is all we can do for her, that could have made our life a little easier. So that would be another thing, just taking care of what you can at the hospital, even though it may be small.
Thank you, Jana, for sharing that. And those examples, I think, are really, really helpful of taking care of the things we can take care of while someone is in the hospital, because you're already going to be navigating such a huge journey with technology. And then also having those changing goals of care from the fetal center to the NICU, changing expectations, doing a better job of communicating what the reason is. And the last thing I'll say is thank you for summarizing what the AAP just released a new statement challenging us all to make sure, as we're partnering with families who have children who may have trisomy, that we are making decisions in the whole context of the child and not just guided by diagnoses. So I feel like I can talk to you guys until January, but I see Tammy's face there. I do want to say to both of you guys, I'm so grateful for your sharing and your bravery. I look forward to the questions that we may have from our audience, and I want you both to know that Haley and Adonis are very lucky that you guys are their parents.
Absolutely agreed. We have, I think, maybe time for two questions that I was going to share from our audience members. The first one is regarding apologies from the medical team. So I'll read the question as written and then maybe provide, a little bit more context. So the question reads, what is the role of apology when the medical team has made an error or there is a communication breakdown? So maybe Taylor, Jana, David, you could share a time where you did receive apology, what was effective or helpful about that, or maybe what wasn't helpful or effective about that apology.
I don't feel like I received too many apologies where we wound up saying like, okay, we were wrong about things. There were instances where we were carrying on a certain way um, with Adonis and his care, and then we later found out that that wasn't it. We weren't fixing what we thought we were fixing during these 6.5 months. The only diagnosis that I mentioned is arthrogryposis, but he has the respiratory failure. He has GERD, a hiatal hernia. Um, and I don't feel like we got too many apologies. Um, there was one time where I did get an apology. I can recall that and I don't mean to be ugly, but it felt just immensely ingenuine from that one person in particular. And so for me that didn't do much. Um, and I can't try to explain, I guess, in details why it felt ingenuine, but it's one of those things where you kind of when you know, you
Wasn't
kind
authentic.
of so I guess hearing that question, I was surprised because I was thinking that we in that field probably wouldn't offer up too many apologies, as that would be like an admission of guilt. But I think that admission of guilt or not, everything doesn't have to be an enormous thing. I think that we're all human regardless of our role. And an apology, if it can go a long way. It can go a long way because whether or not you have the PhD and I just am the mother, we're all human and we can all make mistakes. And just to acknowledge it, because it's all trial and error too, because you can have two people with the same diagnosis and it be different.
Mhm. You're not just a mother. I want to say that. David and Jana, any portion or journey where you recall getting an apology or?
Yeah, we had one time where we were doing they were doing the rounds in the morning and we were there and they were talking about the apneic events that Haley was having and she was having the it's not the central apnea, but it's the other like just where they
Just Brady's.
yeah, Brady's. She was going down. Well, she was having a bunch because she was getting used to new settings or something on her trach. And it might have even been CPAP. I can't remember. But when we were making the rounds, the attending is it the attending?
The doctor.
The doctor said that oh she had 30 something central apneic events and we're like nah she hasn't had a single apneic event a central apneic event which is like the brain saying stop breathing or something and then like she looked at her notes and she was kind of talking and she said I'm sorry I didn't that was wrong I don't know I'm sorry for scaring y'all like that so I mean that stood out I was like oh well okay thank you so
Thank you. I'm amazed at how clear the clarity you guys have in the memory. I'll say from a palliative care standpoint and in the literature, um, we know that apologies to families can go a long way in transparency and acknowledging not necessarily an error in a medical decision, but just in my communication. And sometimes I will stop and say, I'm sorry, can I start over? I'm not conveying myself the way I would like to convey myself. And just giving people a reset and acknowledging that your humanity is there too. And that you're not perfect and acknowledging that you cause harm, that your words cause harm, can go a long way.
And then the last question that we had touches on a theme that I think has been addressed as well in our previous conversation, which is that of uncertainty. And so the question reads, as a parent of a child with an unknown future, do you prefer the spectrum of possibilities or best case, worst case? As a field, we're really terrible at predicting outcomes. And
Okay.
so I guess the question is really about how in acknowledging that uncertainty and the whole whole spectrum of what could happen, how was it most helpful to receive or have that conveyed to you guys? Was it conveyed to you guys?
Spectrum or best case, worst case?
I can say for me personally, I'm a rip the band-aid off kind of gal. I'd rather the cold, hard, ugly truth, the real expectations. And with that, I will still hold on to what I am seeing with my own eyes. Um, when we did those scans of Adonis and they said that his lungs were small and they told me to, prepare for, maybe a couple of hours. Do you want them to take him away or do you want to spend that time with him on your chest? Um, it put me into a place of like sadness and devastation. It did. Because I don't think that that would be easy for anyone to accept. But then seeing him there, seeing him here now, still here. It may not be the best quality of life, may not be having the best time, but he is here. And that means a lot to me. And then just thinking about over the time in the NICU, just a couple of like small comments that were made because of his diagnosis, like we're not expecting much. And so it's okay to to give me the medical explanation. Um, we get an understanding. I do understand what we are medically expecting, but then when I see that my child is showing me he's doing more, if I express a little bit of hope, um, you don't have to share my hope. I understand we all have different belief systems too at that, but that at that point, I don't we don't need to shut it down entirely. Um, yeah. So I prefer the truth. And then also with the uncertainty, there are things that we don't know. I prefer the truth of that too, rather than being told that, oh, it's going to go XYZ and we don't know. Yeah.
Thank you, Taylor. David and Jana?
I think I would say like, telling me the facts, give me, the best and the worst, but don't tell me, oh, this is definitely going to happen because it may not. You know, unless there's 100% chance of it happening, there's a small chance that, something better or worse, of course, could happen. So just, leaving space, kind of like Taylor said, for our faith or hope for, whatever we're wishing for. And
I love that. I do think sometimes healthcare teams in our efforts to provide the clearest information experience sometimes conflict if we don't share the hope that the family shares. Taylor, I love that you said you don't have to share my hope. Like we can hold space for both. I can hold space for the truth, and I can hold space for what I'm seeing and hoping for as a parent. And Jana, you're right. Very rarely in the NICU can we say 100%. So even if it's 99, there's still 1% that is not in holding space for that. To the person in the audience, I would agree with you. I'm 26 years into my career. We don't do uncertainty well. We have challenges with uncertainty. We have challenges with leaning into giving families the hard information, but families have the capacity to hold the hard information and find whatever is going to give them the strength to navigate that, which may look different from the way we navigate challenging issues in our own life. And I think we owe it to our families. We owe it to families like this to allow them to determine how to navigate that and how to filter that. Thank you guys for sharing that. And that was a really, really good question around the uncertainty.
Thank you, everybody. I'm going to go ahead and share our slides again. We do have a bit of things to just close out and some additional resources. So hopefully, are you seeing my slides?
We are.
Wonderful.
Good job.
We will, and this is a disclosure that we didn't get to as the internet went down a little bit. But Dr. Major-Kincade, did you want to talk about the trauma-informed principles and
yes.
then give you some resources for?
I just wanted just quickly, I know that Tammy has the list of these articles linked to it. You guys can scan with the QR code. But just to remind everyone that there are 6 key principles of trauma-informed care that have been kind of modified to the NICU in the Sanders article. And the first thing is we want physical and psychological safety for parents and staff. And so much of psychological safety happens with our words. And for a lot of our families that are admitted to the NICU, there are words that they heard in the fetal center that get perpetuated in the NICU. And just to kind of hold space for the way your words may have impact on families, and just asking families, am I explaining myself okay? Is this okay? Trustworthiness and transparency. One of the things that both Jana, David, and Taylor have taught me is transparency in the discharge summary doesn't always match transparency in our family meetings. We have a lot of family meetings. We may focus on really, really big things, but what are the diagnoses that you're sending the family home with, and making sure we're partnering in transparency for all the things. They have their one of one. We're taking care of a lot of children, but their one of one, everything about that one of one is important. So cultivating trustworthiness there, peer support. This is something that Tammy has on the next slide, particularly making sure families have access to families who have navigated the journey. Most of us in the NICU are not in the follow-up clinic. We're not seeing these children long-term, and families do need to have access to people who are navigating life with their children, doing life with their children, and what that looks like. And just making sure they have access to peer support. Jana and David shared that it was when they talked to the other parent who had gotten the jaw distraction, and it did not improve the journey for their son. They still got the trach that helped them. And I know that for Taylor too, having access to people who were traveling with their child, people who were doing other things besides just going to the clinic the way it was described to her was very helpful. So collaborating families, as we know, families should not feel like they're taking up space or a cog in the wheel. They're the most important part of the medical team, and we're collaborating with them in the care. So just kind of leaning into when we are in that meeting, have we intentionally created verbally and non-verbally space for them to feel present, making sure they're empowered and making sure that we're honoring any cultural, historical, or gender issues that may be contributing to psychological unsafety for our families. I think is really, really important.
So we do have a list of resources that will be available on the Together in Care campaign website if you're interested in reading further on some of these concepts. But we also wanted to very specifically direct those that are interested to the Courageous Parents Network. It is an incredible resource for clinicians, for families, for any child who's going through serious illness. And so if you go to the media library, if this sort of content was helpful for you, these conversations were helpful to you, you can go to the media library, find many more interviews and writings on the family experience. And you can also filter through if you're interested in learning more about the family experience of tracheostomy, for example. They have specific resources based on some of those key filters. And then if you click on the Clinician and Educators tab, you can get access to the portal, which has fantastic resources for clinicians and educators, as well as resources that may be valuable to your families. And the website is courageousparentsnetwork.org. And then if you go to the library and look under the theme NICU, that will provide some very NICU specific or families who have had NICU experiences resources there. And so thank you all so much for coming again. Our webinar in January, I hope you will be able to join us, will be with Dr. Weaver discussing pediatric hospice concurrent care. And then these are the QR codes for evaluations, CME and MOC Part 2 credit. And an especially huge thank you and gratitude to David, Jana, and Taylor for joining us today. And thank you, Dr. Major-Kincade, for moderating our discussion.
A pleasure. Thanks, everybody.
Thank you all for the opportunity. Y'all take care.
Thank y'all.
Yep, thank you.
Thank you so much. I'll end the webinar, and we really appreciate your participation.